Good morning, everyone. Today's topic is HIV and periodontium. This topic is mainly for the final year UG students. HIV, human immunodeficiency virus, also known as acquired immunodeficiency syndrome, is characterized by profound impairment of the immune system. It was first reported in 1981 and it's a viral pathogen. It was first identified in 1984. The second type of HIV was identified in 1986, which was isolated in Western Africa and renamed as HIV-1 and HIV-2. HIV-2 is similar to HIV-1 and it appears to be virulent, causes AIDS more slowly. Epidemiology of AIDS. As of 2012, approximately 35.3 million people are living with HIV globally. Of this, approximately 17.2 million are men, 16.8 million are women, and 3.4 million are less than 15-year-old. There are about 1.8 million deaths from AIDS in 2010, down from 2.2 million in 2005. Sub-Saharan African in the region most affected. In 2010, 68%, that is 22.9 million of all are HIV cases. 66% of all deaths, that is 1.2 million. The total number of people living with HIV in India is estimated as 2.4 million. 61% is of male and 39% is of female. The four high prevalence states of South India account for 57% of all HIV infections in the country. Andhra Pradesh has around 5 lakhs cases. Maharashtra has around 4 lakhs 20,000 cases. Karnataka has 2 lakhs 50,000 cases. And Tamil Nadu has 1 lakh 50,000 cases. This is a structure that we can be seen in the picture below. Now, mode of transmission. HIV detected in most body fluid including blood, semen, vaginal secretion, cerebrospinal fluid, breast milk, urine, sexual contact, blood transfusion, and needle sharing. Perinatal transmission has two routes, that is intrauterine and postnatal. Occupational exposure, organ transplantation, and artificial insemination. Classification and staging of HIV. Now, the WHO stage 1990 and the revised was on 2007. Now, clinically, stage 1 is the asymptomatic infection or persistent generalized lymphadenopathy. Clinical stage 2 are the mild symptoms. That example are weight loss, angular cheilitis, herpes zoster, fungal infections, etc. Clinical stage 3 are the advanced systems, that is of chronic diarrhea, severe weight loss, pulmonary tuberculosis, and so on. Clinical stage 4 severe symptoms are HIV wasting syndrome, that is chronic herpes simplex infection of more than 1 month duration, extrapulmonary tuberculosis, Kaposi sarcoma, esophagocandidiasis. WHO classification of HIV associated clinical disease are the following charts, that is clinical stage 1, clinical stage 2, clinical stage 3, and clinical stage 4. Where clinical stage 1 has been asymptomatic, clinical stage 2 unexplained weight loss, clinical stage 3 are the unexplained severe loss, that is more than 10%, clinical stage 4 are the pneumocytic pneumonia. Now going next to the slide. Classification and diagnostic criteria for oral lesions in HIV infection, which was 1993 revised. In group 1, lesions strongly associated with HIV infection, candidiasis, hairy leukoplakia, Kaposi sarcoma, non-Hodgkin lymphoma, periodontal disease, linear gingival erythema, necrotizing ulcerative gingivitis, and necrotizing ulcerative periodontitis. Group 2, the lesions less commonly associated with HIV infection, bacterial infection like Mycobacterium avium, Mycobacterium tuberculosis, melanohyperpigmentation, necrotizing ulcerative stomatitis, salivary gland, thrombocytopenia purpura, and then ulceration not otherwise specified. Viral infection, dry mouth due to decreased salivary flow, unilateral or bilateral swelling of major salivary gland. Now, group 3 lesions seen in HIV infection were bacterial infections like Escherichia coli, Actinomyces israeli, cat scratch disease, drug reaction, ulcerative erythema piriform, Lichenoid toxic epidermolysis. Fungal infection other than candidiasis are Cryptococcus neoformis, Neotrichum candidum, Histoplasma capsulatum, and so on. Now, management. Antiretroviral drugs can be given: one that blocks binding of HIV to target cell, one that blocks viral RNA cleavage, and one that inhibits enzyme reverse transcriptase. Ideal requirement should be as specified as possible, should reduce viral production from infected cells, can be administered orally, should cross blood-brain barrier easily, should not develop resistance, and should not be toxic. Here, what is the role of a dentist? Provide routine dental care for HIV-infected individual, understand the significance of oral health lesions with HIV disease, and perform evaluation, diagnostic, and institution treatment. Collaboration with other health care workers and social support system involved in the overall care of HIV-infected patients. Lesions that are commonly associated with HIV infections are as follows. Classification: primary oral candidiasis as acute, chronic, acute pseudomembranous and erythematous, chronic hyperplastic erythematous, pseudomembranous. Candida-associated lesions are denture stomatitis, angular stomatitis, medium rhomboglossitis. Characterized primary lesions superinfected with Candida, leukoplakia, lichen planus, lupus erythematosus. Secondary candidiasis as manifestation of systemic mucocutaneous candidiasis, thymic aplasia, and Candida endocrinopathy syndrome. Oral candidiasis, pseudomembranous membranes. Here we can see it's a picture where this transformation, superficial infection of upper layer of oral mucosa membrane, fungal growth, desquamation of epithelial cells, and accumulation of bacteria, keratin, and necrotic tissue forming pseudomembranous. Atrophic and erythematous candidiasis. Acute atrophic candidiasis, that is erythematous candidiasis, commonly occurs slugging of the truss pseudomembrane. This condition is associated with broad-spectrum antibiotic therapy, glucocorticoid use, human immunodeficiency virus infection. The most common location of these are the dorsal surface of the tongue, where there are patchy depapulated areas with minimal pseudomembranous formation. They are both symptomatic and asymptomatic variant, later which is characterized by burning or pain. Median rhomboglossitis of the tongue, presenting smooth, red, depilulated area in the middle of the tongue. Hyperplastic candidiasis, the clinical features are buccal mucosa, commissure of the lip, bilateral, raised irregular palpable, white plaque, hard and rough to touch, speckled and nodular. They are firm, white patches. The site are usually seen in the cheek, lip, and tongue area. Appearance are firm and white leathery plaque. Angular cheilitis. This is usually also called as perliche, is characterized by erythema, fissuring, maceration, and soreness at the angles of the mouth. These are commonly seen in those patients who have the habit of liquors, usually in young adults and elderly patients with sagging skin at the oral commissure. Loss of dentition, poorly fitted dentures, malocclusion, and riboflavin deficiency may be also one of the factors. Management. More advanced lesions, including hyperplastic candidiasis, may require systemic antifungal drugs. Early oral lesions, HIV-related candidiasis, are usually responsive to topical antifungal therapy. Most topical antifungal agents contain large quantities of sucrose, which may be cardiogenic after long-term use. Fluconazole oral suspension, chlorhexidine, and cetylpyridine chloride oral rinses may also be effective fighting against oral candida infection. Systemic antifungal agents such as ketoconazole, fluconazole, itraconazole, and amphotericin B are also effective in treatment of oral candidiasis. Long-term of ketoconazole may induce liver damage in individuals with pre-existing liver damage. Now, the increased risk of chronic hepatitis B or hepatitis C infection in immunosuppression individual may put some patient at risk for ketonazole-induced liver damage. If ketonazole is prescribed, patients should receive liver function tests as baseline as at least monthly during therapy. Topical drugs are as follows. Those are clotrimazole, that is 10 mg tablet dissolved in mouth with 3 to 5 tablets daily for 7 to 14 days. Nystatin, clotrimazole ointment can be used. Miconazole, the 2% ointment, can be used. Amphotericin B oral suspension can be used 4 times daily for 2 weeks, and so on. Coming to oral hairy leukoplakia, the clinical features are corrugated white lesion on lateral and ventral tongue surface in immunodeficient patient associated with HIV positive adults, AIDS, organ transplant, prolonged steroid therapy, lateral ventral dorsal border of the tongue, and bilateral. 25% are HIV positive adults, not common in HIV patients. 80% can be seen in AIDS. Now, studies have also shown that associated with intraepithelial proliferation of the immunoherpes virus, the Epstein-Barr virus, that's the EBV, and the multiple strain of the virus are often present in OHL tissues by Amatona in 2001. Siki Green et al. In 2002 also stated OHL is the only lesion caused by EBV in which the virus replicates and is commonly shed in saliva. Microscopically show hyperkeratotic surface with projections with similar hairs that resemble hairs, and beneath parakeratotic surface acanthosis and some characteristics balloon cells resembling coilocytes are also seen. This is the histopathology that being here, where epithelial dysplasia is not a feature. Little or no inflammatory infiltrate is present beneath connective tissue. Differential diagnosis can be carcinoma, dysplasia, frictional and idiopathic characteristics, lichen planus, tobacco-related leukoplakia, and so on. Management. Now, coming to management, oral hairy leukoplakia generally does not require treatment. Resolution has also been reported that therapy with acyclovir, zidovopin, and other drugs, but usually reoccurs when treatment is discontinued. Laser or conventional surgery. Non-Hodgkin lymphoma. This is 70% B cells and 30% T cells. Viruses include HBV, that's a herpes virus, herpes virus 8, HIV, all are implicated here. Malignant proliferation of lymphocytes. Signs and symptoms of non-Hodgkin lymphoma includes painless superficial lymph node enlargement, systemic B symptoms, extranodal involvement, including GIT, lung, brain, testes, thyroid, and skin. Occurrence are more common in the gingiva. It has characteristics of white varicose surface of necrosis of the gingiva resembling a nub. The treatment for this are anti-malignancy drug, surgical excision, or radiation therapy. Kaposi sarcoma. Now coming to Kaposi sarcoma is rare, multifocal vascular. Median survival time after onset of Kaposi sarcoma is 7 to 31 months. A vascular malignancy that occur any place in the body, including the internal organs. But the first lesions often appear on the face or in the oral cavity. Coming to histopathology, microscopically it consists of 4 components, that is endothelial cell proliferation, extravascular hemorrhage, spindle cell proliferation, and mononuclear inflammatory infiltrate. Differential diagnosis includes pyogenic granuloma, hemangioma, atypical hyperpigmentation, angiosarcoma, cat scratch disease, etc. Coming to management, treatment includes use of antiretroviral agents, laser excision, radiation therapy, injection with vinblastine, and interferon alpha or other chemotherapeutic drug. Nicholas et al. Stated in 1939 that described he described the successful use of intralesional injections of inblasting at a dosage of 0.1 mg using a 0.2 mg solution of vinblastine sulfate and saline. Intralesional injections with sodium tetradecyl sulfate. Oral ulcerations. Now, people with HIV present with oral ulceration of diverse etiology. The ulcerations may be infectious in nature. Herpetic stomatitis caused by herpes simplex virus are commonly seen in HIV infected patient and has a tendency to reoccur. Aptus ulceration may be small or large, single or multiple. Minor aptus ulcer are painful, round, well circumscribed with a whitish covering surrounded by a erythematous halo, usually limited to the non-keratinized mucosa of the soft palate, buccal mucosa, tongue, or tonsillar area, but can occur anywhere in the mouth. Lesions also can be seen in gums, hard palate, vermilion border of the lip, and adjacent facial skin. In HIV infected people, the lesions are chronic, recurrent, and may progress rapidly to cause extensive mucocutaneous involvement that may persist for several weeks and may extend to esophagus. Now, Ebstein's ulcer are deeper than herpetic ulcer and have a well-defined edge and persisting vascularization of characteristics of herpetic lesion, large lesion progression, chronic, and they heal slowly. They are often interfered with speech and swallowing and may contribute to inadequate oral intake and rapid weight loss. Atypical ulceration. The higher incidence are seen in HIV infected patients. They are atypically large, persistent, non-specific painful ulcers. It is caused by herpes simplex virus, varicella zoster virus, Epstein-Barr virus, and cytomegalovirus. Resistant viral strains are treated with forcatinib, anciclovir or valaclovir hydrochloride. Topical corticosteroid fluconazole can be applied 3 to 6 times daily. Oral hyperpigmentation. Now, coming to oral hyperpigmentation, this pigmentation may be related to prolonged use of drugs such as zidovudine, ketoconazole, or clofazimine. Zidovudine is also associated with excessive pigmentation of the skin and nails. Oral pigmentation may be caused by adrenocortical insufficiency caused by prolonged use of ketoconazole. Some reports have described an increased incidence of NUC among HIV-infected individuals, although this has been sustained by other studies. Coming to necrotizing gingivitis, clinical features are HIV-related necrotizing gingivitis. In acute stage, ulceration, necrosis, and slugging may be seen in radiohemorrhage and characterized fetor. The anterior gingiva is mostly commonly affected, given by Greenspan in 1993. Now, treatment. Basic treatment may consist of cleaning and debridement of affected areas with a cotton palate soak in peroxide after application of a topical anesthetic. It is contraindicated in immunocompromised individuals. Adjunctive use of metronidazole and actinomycin agents in this patient is reportedly to be extremely effective in reducing acute pain and promoting rapid healing, given by Scully et al. Necrotizing periodontitis. Clinical features. According to this description given by WHO, soft tissue loss as a result of ulceration or necrosis, exposure, destruction, or sequestration of bone may be seen. The distinctive features are loss attachment. Coming to treatment, local debridement, scaling and root planing, irrigation with an effective microbial agent. In severe NUP, antibiotic therapy may be necessary but should be used with caution in HIV infected patients to avoid an opportunistic and potential serious localized candidiasis or even candidal septicemia. Diagnostic tests that can be taken up are ELISA test, Western blot, the P24 antigen, lab on chip. General precautions that have to be taken during procedures are surgical gloves should be worn when touching blood, saliva, or mucus membranes. Surgical masks and protective eyewear should be worn. Disposal or washable gowns should be used. Instruments should be sterilized by autoclaving. Debris should be moved by scrubbing with soap and water before sterilization. Surface should be decontaminated with sodium hypochlorite. The needle should be disposed with safety guard. Droplets and aerosol production should be avoided where possibly by use of rubber dam and high-speed evacuation. Apparent fumigation of an operating room is required as a part of disinfection. Psychological factors. This is the major means that we have to be taken care of while treating HIV patients because they'll be mentally stressed, so we have to know how to deal with them. So coming to their psychological factors, patient may be greatly concerned with the maintenance of medical confidentiality, and it must be upheld. Coping with life threatening disease may elicit depression, stress, anxiety, and anger towards the dentist and staff. Importance to display concern and understanding the patient situation. Treatment should be provided that in a calm, relaxed atmosphere, and stress to the patient should be minimized. Coming to conclusion, the pathogenesis periodontal disease in HIV positive subjects may be due to microflora, the effects of HIV and other viral agents, and alterations in the host response. These factors should be taken into consideration in the treatment and prevention of periodontal disease in the HIV patient. Thank you.